microbiological sample, send it to the laboratory, and once I have the results, then I will take the decision. Professor Mombelli said that this is costly. I don't know what is costly, but it's, I mean, 60 to 90 euros. We are in London. The taxi from Heathrow to my hotel was 120 pounds. So maybe costly is taking a taxi to go from Heathrow to the hotel. But of course, microbiological diagnosis has another cost, but is within the range of 50 to 100 euros, which I don't think, I mean, it can be afforded by patients in Europe. Which are my line of thought to suggest that we may want to use microbiological testing? Especially if we want to use amoxicillin plus metronidazole. And this is an old story. When I was young, yesterday, the combination of amoxicillin plus metronidazole was named as the Van Winkle cocktail. Van Winkle cocktail, because he did with his group, he did the research in the late 90s, sorry, and it was developed to kill Aggregatibacter actinomycetes. And there are clinical and laboratory research to prove that it's a combination which is very effective against Aggregatibacter actinomycetes. Second thing, it tends to show better results in Aggregatibacter actinomycetes comitans periodontitis. Already the paper by Adrián Guerrero has been presented by Professor Van Winkelhoff, and the papers by Thionka and Mombelli have been presented by Professor Mombelli. And the summary of these results is that in aggressive periodontitis patients, at least, it seems that AA patients benefit more than AA negative patients. In chronic periodontitis, it's not that clear because the studies by Professor Mombelli show that there were no difference, but previous studies, like the one by Fleming, show that AA positive patients benefit more. And it is very important, the paper of Guerrero, because this is the paper that started the whole thing. So after this paper, everybody started to prescribe amoximetro to all the aggressive periodontitis patients, and a lot of studies started to be conducted in many places in the world. And the same data is now the data that is telling us that the AA patients in this particular study benefit more from the amoxicillin plus metronidazole regime. Not all patients, specifically those AA patients. And also, I come back to this slide. If we prescribe amoxicillin metronidazole empirically to all the patients without a microbiological testing, we are probably over-treating 95% of the patients in Spain who does not harbor AA. You may ask me, would you use empirically, based in clinical data, amoxicillin plus metronidazole in Morocco? It may be, because then you have only chances of over-treating 40% of the patients. In addition, clinical diagnosis is not able to predict the presence of AA or any other periodontal pathogen. And we have solid proofs for that, including a systematic review presented at the European workshop by Andrea some years ago. And this has been also shown previously by A.J. Van Winkelhoff, the differences between amoxicillin plus metronidazole versus metronidazole alone exist, but they are not statistically significant. Normally they are not statistically significant. At least in these papers that I am presenting here, of course amoxicillin plus metronidazole showed better results, but this was not statistically significant for most of the outcome variables that were included. And this is also shown in this systematic review that included many different drugs, and you could see, I don't think you could see because I could not see myself, but you have to believe me or read the paper, which is published, of course, that the results for amoxicillin were better, but the results for metronidazole alone were also good. And this is a logical statement. 2 drugs versus 1 drug means that you have double cost, double risk of adverse effects, double risk of increase in bacterial resistance. And we all know that penicillins kill people. It is estimated that in the United States, 400 persons die every year because they have taken penicillins and they are allergic to them. But sometimes you find a paper, in this case it's a letter, that summarizes what you were thinking about this topic. And this is this letter by Preuss and co-author that said, and it was a comment on the previous systematic reviews by Esgolastra and Pinstra, and they said that it was difficult to take a clinical recommendation from those reviews based on the heterogeneity of the results, based on the short-term follow-up of the studies, based on the not very clear criteria for selecting the antibiotic, meaning that it was empirically selected, and also in the not very well-defined overall clinical treatment strategy. So I advise you to read this paper, but when you read it, then you will find something. And it's not me who is recommending you to limit the use of systemic antimicrobials and do microbiological testing. It's the World Health Organization in the European Union and something called ACDC that Professor Van Winkelhoff mentioned, that said that unnecessary use of any antibiotic should be avoided, that narrow-spectrum antibiotics should be used whenever it's possible, and that broad-spectrum or combination antibiotics should be avoided except in cases of severe infection that do not respond otherwise. And microbiological diagnosis is advised before selecting an antibiotic against infectious diseases in general. So let me summarize and conclude that systemic antimicrobials may have a role in the treatment of periodontitis since they are infections, and mechanical periodontal therapy has limitations. It's cheap and easy, and that's the problem. Our students in the postgraduate programs learn very easy to prescribe drugs. I mean, you can do it with 5 seconds. And may improve the results, and this is solidly proven by systematic review. But there are problems for the patient and for the society. Adverse effects, increasing microbiological resistance. So the suggestion is use systemic antimicrobials in periodontitis, but restrict that use for specific patients and specific conditions. And once you decide to use it, then do it under the most optimal conditions. Professor Van Winkelhoff, I'm in the extra time now. I take 3 minutes of Professor Mombello. So the restriction should limit the use to some clinical conditions, and the list is here, but not all the patients with aggressive periodontitis, not all the patients with severe form. Some of these patients in which your clinical criteria suggest that you need the best treatment available. And also, the optimal conditions include that you should use adjunctive lithoscaling and root planning with immediate prescription after debridement, that the debridement should be accomplished in a short period of time, not meaning in 10 minutes, but not with some days between the debridement, and with the best quality. And combining both the restriction of use and the optimal condition, the recommendation is the microbiological identification of the target is desirable in order to select the agent that you are going to use, and in order to select the patient that actually needs the prescription. So with that, I want to thank again the chairman and all of you for your attention.